going back to our case, we described a patient who initially had is diagnosed with stage 3 disease, and within 1 year, actually 9 months, the patient developed metastatic disease. Deciding about how to approach our patient and treatment options, we did identify the patient's functional performance status did go from an ECOG of 0 to an ECOG of 1. We did discuss that the patient did have disease recurrence within a year. So those two parameters did now categorize him as being intermediate risk. Things that we always think about when it comes down to options of therapy does include, obviously, important factors that are not on that list. The important factor we do discuss is performance status. I think that we have to recognize that even though it's part of risk categorization, this is very subjective by the physician. I think that we have to ask more questions to identify the risk of the patient's functional performance status. We do recognize that the patient's functional performance status can predict the patient's tolerance to therapy. And I think the longevity of being on a therapy due to the patient's tolerability does give the patient the potential benefit for having him be exposed to these therapies for a longer basis. Other items that are not usually considered in risk stratification is sites of disease, number of metastases, and yes, it's the disease burden. I think that when we talk about what therapies may be a quicker onset of action, what therapies may be better tolerated, I think we have to consider the visceral involvement of the patient's sites of disease. And really, sometimes, despite the fact that the patient may have a large volume disease, the patient may be asymptomatic, which may be helpful in deciding what options of therapy we have to give. Therapies include oral tyrosine kinase inhibitors, significant benefit in regards to the patient's freedom from the office. Patients may have different types of toxicities to oral tyrosine kinase inhibitors, GI toxicities, fatigue, hypertension, rashes, wound healing issues. So I think that despite the fact that these therapies are also having the ability to be toxic, they also have an ability for adjustability. So you can actually lower the dose of an oral therapy, allow it to be more tolerable, allowing the patient to remain on the therapy. VEGF inhibition seems to be a very strong component and action against patients with renal cell carcinoma, as anti-angiogenic properties to a very vascular disease. Patients tend to respond well to oral tyrosine kinase inhibitor therapy. The newest forms of therapy being immunotherapy, intravenous immunotherapy, several agents we have available, initially utilizing nivolumab as a single agent for second-line therapy in November 2015, and now the evolution of utilizing these therapies in first-line therapy, either in combination of immunotherapies, that being ipilimumab and nivolumab, or oral tyrosine kinase inhibitor therapy combined with VEGF inhibition, combined with immunotherapy, that being axitinib and avelumab, axitinib and pembrolizumab. We are definitely deriving benefits, and though we are utilizing two mechanisms, we are definitely seeing a benefit in not only response rates, but durable response rates, and more importantly, in complete remissions. As first-line therapy for patients, again, we have to talk about categorizing these patients in favorable risk as well as intermediate and poor risk. Again, utilizing patients in favorable risk, one has the opportunity of putting patients on oral tyrosine kinase inhibition, that being either sunitinib or pazotinib. However, based upon the Keynote 426 clinical trial, we see patients receiving axitinib and pembrolizumab do have benefits in patients with benefit in favorable risk categorizations. In intermediate and poor risk categorizations for first-line therapies, we also still do have axitinib and pembrolizumab, as well as axitinib and avelumab, single-agent cabozantinib, and then based upon the Checkmate 214, the combination of ipilimumab and nivolumab. In patients who have progressed after first-line therapy, the consideration of second-line therapy has several factors. Of course, it does concern ourselves with patients' functional performance status, tolerability of the first-line therapy. I do believe patients who've actually had a good response and a durable response to first-line therapy may predict their response to second-line therapy. And that really comes down to when do we utilize immunotherapy as a second-line therapy if they receive prior immunotherapies, or tyrosine kinase inhibition after receiving prior immunotherapies? Do we continue the same mechanism? Do we do a switch mechanism? The sequencing about how to take care of patients has been studied, and I think that beyond the patient's ability to tolerate systemic therapy, I think our patients have to be able to recognize the potential long-term benefit of receiving second-line therapy.